Hi, this is Nasreen Kesani from Mount Sinai School of Medicine, and today I'll be talking about use of PET-CT scan in management of lung carcinoma. As we know that lung cancer is a leading cause of cancer-related death in the United States. In 2021, there will be anticipated 240,000 new cases of lung cancer and approximately 132,000 deaths from lung cancer. The 5-year survival rate of lung cancer in last decade has been around 22%. The overall lung cancer is the third leading cause of cancer after breast cancer and prostate cancer. However, it still continues to be the leading cause of death, cancer-related death, topping both prostate and breast cancer. At the time of diagnosis, approximately 18% of patients will have a cancer limited to the primary site. Approximately 22% of patients will have regional nodal metastases, and approximately 56% of patients will have distant metastases. The survival is definitely dependent on the stage of diagnosis. So if patient is diagnosed at the localized stage, the 5-year survival will be approximately 60%. With regional nodal metastasis, it goes down to 33%. And with distant metastasis, the 5-year survival is close to 6.3%. So as you can see, the stage of diagnosis is very important. As we know that there are two main types of lung cancer, non-small cell lung cancer and the small cell. In non-small cell lung cancer, there are several varieties. The most common ones are the squamous cell carcinoma, large cell carcinoma, and adenocarcinoma. There are several uncommon varieties, and most interesting of those uncommon varieties is carcinoid tumor. There are two types of small cell lung cancer, small cell that is oat cell variety and the combined small cell. Today, we'll mostly concentrate on the non-small cell lung cancer. PET-CT is still not included in the management of small cell lung cancer yet, but there are evidence showing that it actually is as effective as non-small cell lung cancer. So the optimal management of the non-small cell lung cancer is dependent on the histological subtypes, molecular characteristics, and as we discussed, the stage of the tumor. So the FDG PET-CT scan has been increasingly employed in the radiotherapy planning, prediction of the prognosis in terms of the tumor response to the treatment, and evidence, as I mentioned, is accumulating that small FDG PET is actually useful in the small cell lung cancer as well. So what is PET, or positron emission tomography? So in positron emission tomography, we use a radioactive compound, a radioactive element, and it is labeled to something which is known to biologically active compound. So for most commonly used radioactive compound we have right now is fluorodeoxyglucose. And in fluorodeoxyglucose, the element is fluoride and the biologically active compound is glucose. This compound is injected intravenously, and based on the metabolism of the patient, drug localizes in the patient. Isotope decays and emits positron. But positron travels approximately 2 millimeters into the matter and combines with the negative electron, and the annihilation takes place. When annihilation takes place, it emits two 511 keV photons, 180 degrees apart, and the detector is placed 360 degrees around the patient, and it should detect two photons coming exactly 180 degrees apart on the either side of the detector. And this is what we call coincidence counting. What is fluorodeoxyglucose? As I mentioned, it's the analog of glucose. It transported through the cell membrane via glucose transporters. Once inside the cell, it gets phosphorylated by hexokinase to 2-deoxyglucose 6-phosphatase. And further catabolism in the Krebs cycle does not occur because it lacks oxygen at the C2 atom. So once inside the cell, FDG remains trapped, and it does not get metabolized, and that is very good for us, because then we can use this compound for imaging. Because of the high glycolytic rate and overexpression of glucose transporter GLUT1 in the tumor cells, FDG is taken up by a variety of tumors. The uptake is dependent on the metabolism or the proliferative index of the tumor. So highly metabolic tumor, highly proliferative tumor will have a higher FDG uptake. And the low-grade neoplasia like prostate and thyroid will have less uptake. There are actually no absolute contraindication of doing FDG PET scan. Sometimes the relative contraindication is hyperglycemia, and if patient's body habitus is, if patient is above the limit of our camera system. But these are very relative contraindication. Now, FDG PET has been used as a standard of care in the management of non-small cell carcinoma. It's included in all the guidelines, including NCCN guidelines, Society of Nuclear Medicine guidelines, and European Association of Nuclear Medicine guidelines. So what are the use of FDG PET in carcinoma of lung? So that was the first indication ever to be approved by FDA, was the characterization of indeterminate solitary lung nodule. So if patient is getting CT scan for lung cancer screening or for whatever reason, and we find the lung nodule, if the nodule is over 5 to 6 millimeter, or in some instances over 8 millimeter, based on your camera system, PET-CT can be used for further characterization. Once the diagnosis of lung cancer is established, you can use FDG PET for nodal staging and for distant metastasis. Our radiation therapy colleague actually used that FDG PET CT scan for therapy planning. And once you start the treatment, a neoadjuvant treatment or radiation or chemotherapy treatment, you can use FDG PET to monitor how the patient is responding to treatment. Later on, once patient is in the remission, or patient has had completed surgery, adjuvant chemotherapy, then you can use in some instances for surveillance of lung cancer. So in solitary lung nodule, as I said, this was the first indication to be approved by Medicare and Medicaid, CMS, in 1999. So in some meta-analysis, encompassing pulmonary nodule, PET was found to be 97% sensitive and 78% specific for diagnosis of malignancy. Here we have a subject, a 70-year-old female undergoing PET-CT scan. She was found to have a lung nodule, and you can see that there is a lung nodule around 1.5 to 1.7 centimeter in the right upper lung and has a very high intense uptake. So you can tell that this is actually possibly malignant. There are some benign condition that would have FDG uptake, high FDG uptake, but in most, it's most possible that this is a lung cancer. We have another patient here with the lung nodule at the lung base, and you can see there is still some uptake in this lung nodule. Unfortunately, the lung nodule at the lung base is, because of the diaphragmatic motion during the respiration, the lung parenchyma moves along with the diaphragm due to deep breathing, and the nodule moves with the diaphragm, and the uptake can spread over several slices. And the lung-based nodule could be slightly less avid compared to the upper lung nodules. But this is still positive, and this was biopsy-proven malignancy. So in pre-treatment staging of lung cancer, it is actually quite routinely recommended. It can help you in diagnosing the mediastinal nodal staging, and also to diagnose remote metastasis. So in staging of lung cancer for mediastinal lymph nodes, the sensitivity is 80 to 90%, and specificity is close to 85 to 100%. The sensitivity and specificity both drop somewhat for hilar lymph node, because hilar lymph node have a higher tendency of having inflammatory lymph node, and FDG PET can be false positive. The greatest strength of FDG is in very high negative predictive value. So if the FDG PET scan shows just the primary neoplasm and there are no nodal uptake, no mediastinal or hilar lymph node uptake, then the negative predictive value of FDG PET is close to 95%, and these patients can be safely sent for surgical resection with high degree of confidence. For staging of lung cancer, so recently AJCC guidelines have changed, and the T1 tumors can be further, in the prior guidelines, prior staging, the T1 was any tumor less than 3 centimeter. Now we divide T1 into T1A, T1B, and T1C based on the size of the tumor. So here you can see that this tumor is around 1.3 centimeter with very high uptake, and this is possibly T1B lung cancer. We have another patient where this lesion is approximately 3.3 centimeter. So it is greater than 3 centimeter, but less than 5 centimeters. So this is a T2 lung cancer. There is no involvement of the mediastinum. It's away from the chest wall. So this is a T2 lung cancer with no mediastinal or hilar lymph nodes or distant metastases. Here we have a third patient where you can see that there is a large consolidative component. Uptake is limited to a small area or a relatively small area close to hilum, but the distal consolidation does not have uptake, and it's a post-obstructive pneumonia. So FDG PET can be actually safely distinguishes between the active tumor and the post-obstructive pneumonia and delineates the tumor nicely. This is actually of very good value in therapy planning, as the radiation oncologist can delineate the tumor nicely and avoid radiating the post-obstructive pneumonia that is healthy lung. This is one very interesting case. This is the cavitary nodule. It's a pleural-based cavitary nodule, and there is increased FDG uptake in this patient. I still don't have the diagnosis confirmed in this patient. This patient is coming from the area that is endemic for tuberculosis, and patient's quantiferon gold is high. But because of the history of smoking, the surgeon is quite confident that this is a primary lung neoplasm. But this is a nice cavitary nodule with a somewhat thick wall, and it will be interesting to know what is the diagnosis. And again, there are no mediastinal or hilar lymph nodes, and there is no evidence of distant spread. Another lung cancer, it's approaching the chest wall, but again, you can see the difference where the post-obstructive pneumonia is non-FDG avid, but the tumor itself is very FDG avid. This is a cavitary, not a cavitary nodule. This is the large mass with area of central necrosis. The central necrosis is usually non-avid on PET-CT scan. Currently, radiation oncologists don't delineate between the necrotic area and the active area, but in future, this will have a value because necrotic centers don't respond to radiation therapy very well, and the avid area responds to radiation therapy very well. So it may have a future role in distinguishing the active area and the area of hypoxia, which is the central necrotic area. What is T3? So T3 tumor is greater than 5 centimeter, less than 7 centimeter, or it is any tumor that has an invasion of the pericardium or invasion of the chest wall. So here in this patient, you can see that the mass is around 4 by 2.5 centimeter, but it is abutting the mediastinal pleura. So it is probably causing the invasion of the pleura. So this is actually T3 neoplasm. Even size-wise, it's between T2 and T3, but because of the chest wall, this is definitely now it becomes T3. Here we have a PET-CT scan with the large right upper lobe mass, definitely greater than 5 centimeters. So it's probably T3 neoplasm. As you can see, it's actually causing invasion into the chest wall, extending into the intercostal muscles area. The rib adjacent to that has some area of sclerosis, so probably rib invasion. And you can see there are lymph node involvement here. There is a hilar lymph node and there is a right paratracheal lymph node. So the ipsilateral mediastinal lymph node becomes T2. So this is a T2, N2, T3, N2 primary lung neoplasm. This one is what makes T4. So T4 is when there is a large mass greater than 7 centimeter, or there is involvement of any of these structures, trachea, mediastinum, heart, great vessels, or vertebral body. So here we have a large left upper lobe mass. It's abutting the mediastinal pleura, abutting the trachea. And on the sagittal section, you can see that the primary neoplasm is extending right into the vertebral body, causing invasion of the T2 and T3 vertebral bodies, possibly extending into the spinal canal. So it's a very large tumor causing destruction of the vertebral body and possibly invading into the spinal canal. So this is a T4 lesion. Again, you can see that there are no other metastatic lesions. It's basically large primary tumor invading the vertebral body, but it has not caused any nodal or distant metastasis. So now we will talk about the value of FDG PET-CT scan in detection of the distant metastases. Here we have a patient with a large left upper lobe mass. It's abutting the pericardium. So it is already T3, abutting the chest wall. So it is T3 tumor, but it is already causing several rib lesions and liver metastasis. So these are the left lobe liver metastasis. Here we have a segment 8/segment 7 lesion in the liver. There are several bone lesions in the sacrum, iliac crest, and in the right acetabulum. Interestingly, this patient also has a large lesion in the right skull base. It's invading the hypoglossal canal and jugular foramina. With the jugular foramina, it's causing invasion of the vagus nerve. So the recurrent laryngeal nerve is the branch of the vagus nerve, and that is the reason there is a right vocal cord paralysis. You can see that the left vocal cord has compensatory hyperactivity, no uptake in the right vocal cord, and it's possibly because the vagus nerve is invaded by the skull-based tumor invading the jugular foramina. We have another patient here. The patient presented with multiple pleural metastasis, no primary tumor, but you can see there are multiple foci of increased uptake, pleural-based foci, some involvement of the hilar lymph nodes. And you can see several pleural-based nodularities in transaxial images. So this is pleural metastasis. Again, it becomes stage 4 disease because of the pleural metastasis. Another patient with the right middle lobe primary neoplasm, subcarinal, and the right hilar lymphadenopathy. But on the whole body scan, you can also see involvement of the iliac crest, left acetabulum, right acetabulum, and another liver lesions. This was a very sad case of 45-year-old woman who presented with left lower lobe mass. Surgeon thought that it's limited to only to the left lower lobe. Patient underwent PET scan. There is, as this is a 45-year-old woman, probably premenopausal, there is uptake in the left adnexa, which is most likely normal, physiologic, but there is a lytic lesion in the right iliac crest, and this has a very high uptake. So this was a biopsy-proven metastasis to the iliac crest from a small left lower lobe mass. No nodal metastasis in the hilum or in the mediastinum, but only solitary distant metastasis. Stage 4 lung cancer, and this was only discovered by PET scan. Now I'm going to show you several cases where patients presented with signs of distant metastasis, and PET CT was used to diagnose the primary site. So in this patient, we see that there is a very hypermetabolic left parietal occipital lesion with intense uptake. When we did the PET CT scan, the CT scan of the chest actually showed extensive lymphoma, and there are all these bullae with one thick-walled area. And on FDG PET, that area had increased uptake, and then there was a right hilar lymph node metastasis. So this was biopsied, and it was confirmed adenocarcinoma of the lung, a scar carcinoma. It occurs in a COPD patient or in any kind of a prior scar. If there could be small thin-walled activity, and this could be a primary neoplasm. Another patient who had a right frontal lobe lesion, patient actually underwent the resection, and it showed lung cancer. FDG PET scan was done because there was in the MRI, there was still post-resection in the surgical cavity, there was still some enhancement. And on the FDG PET scan, you can see that there is still some residual cancer after resection. In the whole body scan, there was only solitary lung lesion. It is a mediastinal pleura-based lesion in the left upper lobe, but no mediastinal or hilar metastasis, just solitary brain lesion. This patient actually survived for another 10 years after he had a radiation therapy to the brain and radiation therapy to the lung. Ultimately, he did develop metastasis and passed away. So there are several lung lesions that can actually have a false negative or no FTG uptake or low-grade FTG uptake. And those are the neuroendocrine tumor and bronchoalveolar carcinoma. Also to keep in mind that if patient is not fasting and patient has a hyperglycemia, it can cause false positive exam. So this patient was actually non-diabetic and not fasting. His blood glucose was around 115. So it was still within normal limit. But when we injected the patient, you can see that the primary neoplasm in the right upper lung has no uptake, but there is diffuse FTG uptake in the muscles. So this is postprandial hyperglycemia, where glucose and injected FTG is going to the muscles and the primary site is not showing the uptake. We repeated the scan after optimal fasting, and now you can see optimal FTG uptake in the right upper lung neoplasm. No mediastinal or hilar metastasis. Now we don't see muscle uptake, and this is uptake in the right upper jaw, probably from dental caries. So the postprandial hyperglycemia can give you a false negative exam. Here we have another patient, 64-year-old who presented with multiple pulmonary nodules, and you can see that there are nodules in the right lower lung, left lower lung, and in the lingula, and none of the nodules have FTG uptake. And in her whole body scan, again, you see that none of the nodules have FTG uptake. So this was biopsied subsequently and was found to have a neuroendocrine neoplasm. So neuroendocrine neoplasm, low grade, particularly grade 1 and grade 2, can be false negative on FDG PET scan. And in those patients, the ideal study of choice is a DOTA-DATE PET CT scan. DOTA-DATE PET CT scan is where DOTA-DATE is a somatostatin receptor agonist, and we label it with either gallium or more recently we have been using copper-64. The normal DOTA-DATE uptake is liver, spleen, and kidneys, just like octreotide scan. And there is a very nice uptake in this patient. Patient actually had a coronary CT angiogram, and the radiologist reading the scan noticed that there were no coronary calcification, but there was endobronchial lesion in the lateral basal segment of the left lower lobe. And we did the PET CT scan, and you can see that endobronchial lesion nicely picking up very high DOTA-DATE uptake. Again, there is no local regional nodal metastasis or distant metastasis. So this patient was resected. Patient had a left lower lobectomy, and patient is doing well. But it was just close to 9 millimeter endobronchial lesion that was incidentally found on coronary CT angiogram. FDG PET would have been negative, looking at this image, because this is a nice, well-differentiated neuroendocrine neoplasm. Mucinous adenocarcinoma of the lung. Again, any kind of mucinous neoplasms, they produce a lot of mucin. They are hypocellular, and that's why they can be low grade or non-avid on FDG PET scan. So this was a large mucinous neoplasm of the right lower lung, and with a very low grade FDG uptake. There is an incidental right axillary lymph node, and you can see that patient's thyroid gland is taking a lot of FDG uptake, a lot of FDG, possibly from thyroiditis. Here I have a very nice case of large cell neoplasm. So large cell neoplasm can also be neuroendocrine derivatives, and on the top we have a DOTA-DATE scan showing the large primary neoplasm, and a lot of nodal metastases and some bone lesions. FDG PET is showing the primary neoplasm, but it's not detecting any of the nodal or distant metastases. So this is the combination of intermediate variety of neuroendocrine type tumor, where FDG PET and DOTA-DATE both can be positive, but DOTA-DATE is more positive than FDG PET. And largely we know that there is a minimally invasive adenocarcinoma or T1A, where the neoplasm is more like a ground glass part solid variety, and FDG scan can be false negative in this neoplasm. PET CT is usually recommended if the solid component is greater than 8 millimeter. On serial scan, if you notice that the solid component is increasing size, then you can use FDG PET. And if it can still have a low grade uptake, but it will be more positive than just the ground glass variety. Here we have a patient who presented with actually brain metastasis. Again, there is a large avid lesion in the left parietal region. On a whole body scan, you can see there is a lot of brown fat uptake, and there is an area of mild increased uptake in the left upper lobe. Again, ground glass variety, not very well-defined tumor, and you can see low-grade FDG uptake, and this was biopsy-proven adenocarcinoma, or previously called bronchoalveolar carcinoma. This patient does have the hilar metastasis that was picked up on FDG PET scan. So we will talk about FDG PET in the treatment monitoring briefly. So there is a patient that I previously showed you with the large right upper lobe neoplasm, and patient had mediastinal and hilar lymph node. On post-therapy scan, patient underwent chemoradiation, and you can see that Both the areas have gone away. This PET scan is done approximately 2 years after the initial PET scan. Here there are several serial scans that were done approximately 3 to 6 months apart. So when patient was undergoing chemoradiation, you can see that slowly there was a decreasing FDG uptake at the primary site and in the mediastinal nodes. Again, in the follow-up, one of the later follow-up scan, the primary neoplasm is much smaller, but now there are areas of increased uptake in the lung parenchyma. And that is usually the radiation therapy changes that you may see for approximately 6 to 9 months after radiation. But in this follow-up scan, at the bottom in the right, that is done 2 years later, and the radiation therapy changes are also gone, and the mediastinal nodes and the hilar nodes are almost gone. There is minimal FDG uptake. The same patient, as I mentioned, that the radiation therapy changes actually progress, but the primary neoplasm is decreasing in size, as you see here. Remember that radiation pneumonitis can be positive, but the appearance will be definitely more looking like a ground glass or consolidative changes, traction bronchiectasis, and when you see that, you should keep that in mind that FDG can be positive in radiation therapy changes, and we should not call it tumor recurrence. We have another patient I showed you earlier with the large right upper lobe mass with areas of necrosis. Patient underwent pneumonectomy, and this is the post-therapy scan 2 years later after pneumonectomy. And you can see that there is no recurrence, no evidence of nodal metastasis or distant metastasis. There is uptake in the vocal cords that is normal. These are the areas of uptake in the ocular muscles, and there is some soft tissue inflammation, but there is no evidence of disease recurrence 2 years later. Another thing to keep in mind is areas of pleurodesis. So this is the patient who presented with very large right pleural effusion. There are areas of increased uptake along the pleural lining. This is at the time of presentation. Subsequently, patient had the drainage done and talc pleurodesis. So the areas of pleurodesis have calcification. So you will see them as calcified plaques in the chest wall. So you can see there is a calcified plaque that was not present before. There are areas of calcification that were not present at the time of diagnosis. The bottom row is the original scan. This is in between scan, and this is the post-treatment scan. So this areas of pleurodesis actually, because there is constant reactive changes going on, they will be positive, and we should not call them as active disease. If you know that patient had a pleurodesis, and if you see these calcified areas, just make sure you confirm that this was, the patient had a pleurodesis done, and we should not call this as a residual malignancy. These are just the changes related to pleurodesis. This is an unusual or unfortunate patient. Patient had a left lower lobe neoplasm, had a radiation therapy. You can see post-radiation therapy consolidation. And in one of the follow-up scan, we started seeing the uptake, and this was confirmed tumor recurrence. So this was a patient who was in the surveillance phase, and FDG PET had diagnosed the tumor recurrence. Just a few unusual cases I'm going to share. This is the patient with the large mediastinal thymoma. You can see that there is a large area of increased uptake in the anterior superior mediastinum, and patient has several lung nodules, and there is a pleural-based metastasis. The pleural-based metastasis you can see in the posterior mediastinum here. As I mentioned earlier, that there is evidence that PET-CT can be used in management of small cell neoplasm as well. So this is the patient with multiple left lung lesion. You can see in this whole body MIP images, and they are all areas of small cell carcinoma. Very avid on FDG PET scan. And it's positive pleural-based lesion, lung-based lesion, and large. This is another interesting variety of PET scan where, or the lung cancer where it's spreading across the infiltrative type, but not making solid component. And this was also biopsy-proven adenocarcinoma of the lung. Here I'm going to end, and thank you for your attention.